just remove this. Okay, so thank you very much. So today I will explain my insight of actually 20 years of research doing omic techniques. And I would like also to focus on the way to recuperate the samples, as we are doing also a review from one of a WG3. And because it is very important from the question I have from a lot of people who come to my team just for doing omics and specifically proteomics, and even they don't know which type of sample they got. So my talk will be divided in four parts. The first will be I will try to convince you why it is important to create a biobank and the reason for this. Then the evolution of omic techniques and my feedback of 20 years of proteomic analysis. And I will suggest you in 2024 which technology that you can use. But I didn't want to make any ads for any company. It's just my opinion after 20 years of proteomic analysis. So when we start, why it is important to create a biobank? Because you will have a project which will be associated with the biobank, and it will help you to identify the feasibility, the type of samples that you need to recuperate, if it is plasma, serum, urine, how many samples you will store, the number of aliquots, the analysis that is planned with the samples, if you will have clinical data associated with the samples. And I just want to remind you that now in Europe, you need to give the effective date of a general data protection regulation, but it is very important, and it's important to know all the regulation. You will need also to estimate the budget for the sample storage at the biological resource centers. Just an example, I don't know if it is in all countries like this, but in France, usually you need to store in a biological resource center. And so it costs money for this. And also you need to estimate the budget for outgoing and incoming sample from this center, and also for the analysis of samples. And usually when we draft for a grant application, we completely forget this budget, which is very important, and it costs a lot of money. And also, you need also for the research data management, you need to draft a data management plans. And for example, in France, when you obtain money from the French government, you need at least twice a year to give your data management plans and how all the sample that you will open, how it could be accessible to other researchers, to the community, because it is, for example, it is money from the French government. In terms also for the feasibility of your project, you need to take into account the duration of the project. That could be completely different from the financing you obtain. So usually we will obtain the grant for 3 years, but you will arrive at the end of the 3 years to have just collected the samples, and you will need to have a budget for all the storage at the BRC, and maybe not all the amount of money for the analysis. Because it could take time, because you will need to have a patient recruitment protocol when you need to recuperate blood samples from patients. But it could take a lot of time. It is the administrative authorization. And also it will depend if it is a single or multi-center study, meaning that you will need authorization for each center. Then you will have the inclusion of patients. You will recuperate the samples. So how the sample will be stored prior to BRC. So it was that we put in the review. When the samples will be analyzed, and also how the clinical data associated with samples will be anonymized, but it is very important with the GDPR. So for the type of samples, usually from patients you will obtain plasma, serum, urine. So for blood and urine sampling, it will be important to know exactly the time between the sampling and the pre-analytical steps, the effect of sample processing time, how the samples are stored if you have planned to make aliquots. For the plasma, there is a key question about the choice of the anticoagulant, depending on the analysis, for example, that you would like to do. If you want to do analysis, I will say for patients with in the field of hemostasis, you will need to use as an anticoagulant the citrate and not the EDTA. And for the serum, it will be very important to choose the pre-analytical steps, and it will be very important to explain to people who will be in charge to process the sample for the blood collecting and after for the blood processing. And it will be very important that, for example, if you are doing a multi-center study, that you will have the information that people can understand all the protocol. Why it is important? So you can see in this slide, depending on the samples collected, you can have an influence of the blood sample processing. For example, on the left, you will have the effect of the anticoagulant. So it is a cell detox profile. So it's like mass spectrometry. So you can see, depending if you have used as anticoagulant citrate, EDTA, or heparin, the profile is different. And the main problem is when the samples are frozen, specifically if they were processed and you have aliquoted. It's impossible to recognize which anticoagulant have been used. And I have seen from my experience that people come to me and even they don't know which type of anticoagulant were used, and usually ask for the color of the tubes. And for example, also the effect of duration for the sample processing. So you have on the right the example with the citrate. So 0 or if the sample is processed immediately or after 4 hours. We did not have so much problem with plasma, but you can see with the serum, between 0 and 4 hours, you have an alteration of protein profile, meaning that it will be very important to have all the protocol carefully written. If not, what you will see, it will be only difference in the process of the samples. I show you the example of the sample stability of plasma EDTA samples, which is my favorite way to recuperate plasma. So I give my blood for this experiment, and we have let the samples at room temperature for 1 hour, 3 hours, 6 hours, and 24 hours. And you can see that the protein profile was completely identical. But never, I will say, at the hospital, you have 24 hours to process the sample. Usually, I will say you need to process the sample within 2 hours. For the serum, it will be very important, and you can have very different depending on the clotting time. So coagulation time is important. You can see depending if you let the samples at 24 room temperature, 8 hours, 2 and 4 hours. This is a mass spectrometry and the identification of the peaks. And you can see that it's completely different. So you need, and I will suggest to use 2-4 hours at room temperature to have a better separation of coagulated samples. But also room temperature, it's really depends if you are air conditioned or not. So this is just to explain the importance of sample processing. And also what it is very important is to aliquot, to limit the number of freeze-thaw cycles. So for the sample analysis that you would like to do, so it will be depending on the type of biomarker you were looking for. If it is protein, just the protein, or the post-translational modification of protein. So I will say that now we have more than 100 post-translational modification. I have written just I will say not the more important, but the more usual post-translational modification that have been studied: phosphorylation, glycosylation, acetylation. Depending also if you want to analyze RNA or non-coding RNA, such as microRNA and long non-coding RNA. And also, you can have as biomarker extracellular vesicles, but probably I will not enter in the detail today on this part. After, you have to choose the technology that you would like to use for your samples. So I have summarized all the proteomic analysis that I have done. But we have started by 2D gel electrophoresis. We are using liquid chromatography MSMS, Luminex technology, Olink and SomaScan, and also RNA or microRNA microarray. And that will be very important. It will be to check for the sample quality, specifically if you will use samples from a study from which you were not involved to set up completely the biobank. The main problem we have, for example, with could be the hemolysis. The way to select your samples that you can after analyze will be to test by spectrometry at 450 nanometers. And if you have an absorbance above of 0.5, you will consider that this plasma is hemolyzed, and I would suggest to not choose. So you can see here a spectra of normal plasma. This is here a plasma slightly hemolyzed, so you have this absorbance. And we also have what we call a milky plasma, because it was completely different. So this is the first step before starting, if you have several aliquots, that you can do to select the samples. Also, just by looking, the samples, if it is, it happens to us, if you have the samples completely dark, I will suggest to not choose it. The other way, it's also to assess, this was done for this study. I just show you as examples. So we are using SomaScan technology, and we have measured hemoglobin and haptoglobin levels. And you can see in this experiment that most of our samples fall into the expected for good quality samples with low hemoglobin level and high haptoglobin level. So it's another way, specifically when you are doing high throughput screening, you can check also for the level of these two proteins and also eliminate samples. But I would suggest to do before, because all of the multidimensional technology costs a lot of money. Other way also, specifically if you want to analyze microRNA, is to quantify the hemolysis by the ratio of the miR451 to miR23A. So this is why? Because the miR451 is expressed in red blood cells, and the miR23A 23A is relatively stable in serum and plasma. And if you have a ratio above 8, you can consider that this sample is hemolyzed, and I would suggest not to use it. The budget. So as I said previously, you will need to include in the budget the storage of the samples in the biological research center, the expected time that you think that you will let the samples, and usually you will have an annual cost for this. You will have a cost for the sample output and dispatch from the BRC, for the sample analysis. Also, if the samples will be returned or for the destruction of the remaining samples, for the drafting of data management plans, if you are not able to do by yourself, and also for the cost of omic data storage. And we forget a lot of this. So depending on the amount of data that you need to store. So for example, in my university, if you have low volume, it will be okay, it will be free. But if you have a lot of data, you will have to pay for this. They didn't have any solution for you. And also for the publication of data, because specifically if you obtain money for your experiment from government, from public government, you are obliged to publish in open access, which is cost a lot of money. So now I will go to the second part, the evolution of omic techniques. So, and I will really focus on the proteomics today, and to explain you that we don't know how to analyze all the protein by proteomic analysis. So usually we will analyze, it's the reason I put these pictures, the top of the iceberg, because we don't know how to analyze all the protein present in an extract, because it will be really depend on what you would like to do and how you would like to use the technology. So I just show you from the UniProt knowledge database, where you can find all the protein which has been sequenced. And this database is constituted of two databases. The database that we call SwissProt, which is that we call now, before they were calling this database the manually annotated database, and now they name reviewed. And Trumbull, it's all the sequence that all the community put in the database, which are unreviewed for the moment. So usually I use only the SwissProt because I'm sure what I'm looking. And you can see that we have a lot of information, more than 500,000 sequences, which are available to the community. We know that we don't have, because you will have all the species. And for example, we have in this database 20,000 entries on protein, which are reference for the human species. And usually, also if you are working with plasma serum, it will be the same. So you have a huge range of concentration of the protein in the plasma, several logs, which means very difficult to study at the same time all the protein, specifically because 60% of the total protein are represented by albumin and total immunoglobulin. And actually we have 20 proteins, which are what we call the main proteome, but usually we are more interesting to analyze what we call the deep proteome. And you can see even in the deep proteome, specifically for the cardiac protein, you have also a range in concentration of this protein, meaning depending on the technology, if you are not using a very sensitive technology, it will be difficult to quantify the protein but they have different concentration in the plasma. So just an example to show that with the facility with the mass spectrometry, we obtain a lot of information in the UniProt sequences, from 2017. And as I have started before, when I was doing mass spectrometry, I did not have amino acid sequence, which I was unable, for which I was unable to identify the protein because they was not in the database. And probably I should go back to all my data in 2D, because at this time we have a lot of spots very important, but we didn't have identified the related protein. So if we consider the evolution of the proteomic technology and the number of proteins that we can quantify in the same samples, you can see that at beginning, we can use a Western blot ELISA, and you will measure one protein in a sample in once. And then we have the technology multiplex, where they add that you can quantify between 12 and 100 proteins at the same time. But you have to pay attention because it happens to us, depending on the concentration of protein. You cannot measure the protein in once. You will need, for example, to dilute the samples. It happens to us with metalloproteases. MMP9 is more concentrated than the other MMP, and to have really reliable assay, we have to do twice the measurement. One, we were using the crude samples, and one, we have deleted 110 to measure MMP9. Then there was the technology of 2D gel electrophoresis. So this technology, I will not enter in the detail, but this technology allow to differentiate the protein by their isoelectric point and the molecular weight. And you can also identify the level of phosphorylation. Usually in 2000, we could detect, I will say, 1,000 polypeptidic spots. And usually in 2000, I will not say now, we will have identified from this 1,000 spots 60 protein. When you have the development of all the mass spectrometry analysis in which that you will measure the peptide, and using a database, you will find the corresponding protein, but you will have never information if this protein was processed, for example, maturation, processing, and you will have just that the peptide recognize the protein. And you have this new technology, which has started in 2011, the Olink, and then the SomaScan. So Olink is a technology that uses two antibodies for two different antibodies which will recognize a protein. And you will have directly the quantification and the name of protein. So they have panel, we will come back to this, of 96 protein that you can measure in one samples. And they provided panels dedicated to pathology. For example, there is two cardiovascular panel, CV, that they name CV2 and CV3. CV2, it is, I will say, the high concentrated cardiac protein, and CV3 will be the low concentrated protein, as I show you, for the deep proteome. And you have the SomaScan, which is a technology which do not use antibody, but what we call SomaMer, which is a small hexamer that will recognize specifically the protein. It is very specific because it can differentiate between for one amino acid in a protein depending on the conformation. And you can see from 2016 until 2021, and I can say now because I went to a Somalogic conference last November, that they at beginning they can measure 1,310 protein, and now they are at half of the human proteome, you know, with more than 11 protein. And so I have used this different technology in order to find biomarker for heart failure. So then I think this is not very good to see. I would like just to show you that with this evolution, so we can measure a lot of protein at the same time. We have now limited time to have all the information, but then you will have a lot of data. For example, with Western blot, we have, I will say, 8 information in 24, 48 hours, depending on the way you are doing the Western blot. And with the Soma scan, when we are doing the first Soma scan with 1,300 protein, we have more that you can see 200,000 information, meaning that you will need to have a collaboration with people to help you to analyze all this data. So I will show you some examples on my experience, just for the Western blot and 2D electrophoresis. So Western blot, you will separate the protein in one gel. So for example, I just show you the example of plasma. So you can see this big, huge band at 60 molecular kilodalton, which represent the albumin. So, and you have just a separation by the size. If you are using 2D gel, you will first separate the protein by their isoelectric point, and then by their molecular weight, meaning that from the same sample, you will have more information, and you can recuperate each spot to analyze by mass spectrometry. So we perform, you know, spot excision. Then you need to use a trypsin because you need to have a small peptide. You need to have peptide to be analyzed by mass spectrometry, and then you will use a specific I will say to cover your protein that it cannot be disrupted by the laser ionization, and then your ionized peptide will be inserted in the MALDI-TOF, and you will measure the flight time of this peptide. And then you will use different software to compare the peptide that you obtain, the list of peptide, to in silico trypsin digestion, which has been made, you know, from the identification of the genome. So from the genome, so you have, they have performed in silico translation to have the protein and the peptide. And actually, you will have a list of peptide masses, and you will consider that you have, because you will have only a p-value to consider that you identify a protein corresponding to the peptide masses, and you will consider that the protein is well identified if you have at least 5 peptides which were used to identify the protein. But for this technology, it will take a lot of time. So just an example, we use this technology to identify the protein in heart. It was a rat which was subjected to myocardial infarction by ligation, and we recuperate a plasma and left ventricle at 7 days after the myocardial infarction and in the late phase of remodeling at 2 months. So this shows you a 2D gel of the heart samples at 2 months, and you can see that we have used bioinformatic analysis to compare each spot in the rat which have a myocardial infection to rat where just have an open and it was the sham rat. And so we have selected 49 spots to be differentially expressed between the two groups. And from this 49 spots, we have only identified 21 proteins. Just an example, at that time when we validate the data, for example, for alpha-beta-crystalline using Western blot, and we observe that the fact that we have identified this spot to be highly abundant in the rat which have myocardial infarction compared to the sham rat. Interestingly, when we look in more detail to the protein, we found that more half of the protein were proteins that can be phosphorylated. And this means that we use this model also to analyze the phosphoproteome, as shown by this slide. But I will not explain, but we can use also 2D gel electrophoresis for to study phosphorylated protein, but we can use also MS technology. For the multiplex technology, so actually this study, REF2, was really dedicated to perform proteomic analysis, and also we were performing microRNA and LNC-RNA microarray. So it was patients which were included, it was a multi-center study. All the red square in the map show you the different hospitals which were involved in the recruitment of the patients. And we asked first, it was patients with the first myocardial infarction, and if they accept to be included in the protocol, so they have echocardiography at the inclusion during the hospitalization and also blood samples. And we gave to each center a very specific protocol to how to process serum and plasma. And for this protocol, it was a longitudinal study. So we have recuperated not only serum and plasma at the inclusion, but also 1 month, 3 months, and 1 year after the inclusion in the protocol. And we performed echocardiography during the hospitalization at 3 months and 12 months in order to quantify the evolution of the left ventricle dilatation. And what we have observed, it was that using the echocardiographic data, that 31% of the patients have a dilated left ventricle, meaning that they have left ventricular remodeling characterized by 20% of dilatation. So we have decided to perform proteomic profile from the 4 longitudinal samples for each patient, and we were using multiplex analysis, meaning so at that time we have XMAC technology. So the interest is that we can use a low volume of samples between 10 and 15 microliter, so which was very good because we would like to save samples. And we decided to perform, all the metalloproteases and all the TIMP, the tissue inhibiting metalloproteases using this technology. And that we can observe that it was protein that was undetectable. For example, the MMP13 was undetectable in the sample. And for example, TIM3 was detectable only in 40% of the patients. And we observe that we have 3 different temporal profiles, an increase through the year after myocardial infarction for MMP2 and 3. For MMP8, 9, and TIP1, we have a decrease in the concentration of the protein. And for TIM2 and TIM4, it was really dependent. So this allows, probably, just to show you, so that we were comparing if you have done these approaches using ELISA, for example, and you can see that with this technology, we could have 400 results, 400 data with one plate using 50 microliter of samples within 6 hours for a cost of 1,200 euros. It was at the time of the experiment. And with the ELISA, using 5 plates, for example, for this 5 MMP, we have only 80 data. We were using more than 100 microliter. The times was nearly 4 times the time for the XMAP, and the cost was twice. So showing the interest of this technology, but as I told you, it really depends. You know, we have tested all the antibody that you can put together, you know, with the beads, but it will be really depend on the concentration of your protein. And so for F2, so we have done all the samples. So we have included 260 patients, and we have 260 patients. So we have performed more than 10,000 essays. It took nearly 2 months to have all the information. So now I will present 3 different technologies, and I will explain you using the same study, ANCA, which was to find, it was patients with heart failure, and we would like to find new biomarker associated with early cardiovascular mortality. We have used several technologies: mass spectrometry profiling, liquid chromatography, multiple reaction monitoring, mass spectrometry, and SomaScan. So we were comparing. It was a case control study. So it was a retrospective study, but we have pay attention to not recuperate hemolysis samples, and we are checking the hemolysis with a spectrometer. So as you can see, the people were very young, less than 60 years, and so we compare. We decided to perform a comparison between the patients which were we were died 3 years after their hospitalization, with the patient who didn't die after 3 years. So from the clinical data, we can see that there are a little bit of patients who died with a proportion of patients with NYHA class 3. And also they have a lower peak VO2, but this is not, peak VO2 is not performed classically in all the cardiological unit. We can see also a little bit more higher BNP level in a patient who died, and also higher creatinine. So with the mass spectrometry, we were using cell-DTOF at this time, and we have divided the patient. So 2/3 was to develop cardiac death prediction, and then we have validated this actually in 2/3 of our population. So to be sure what we have done, it was we use that CPLL treatment of plasma samples, because at the time it was the only way to eliminate a little bit of the abundant proteins such as albumin and immunoglobulin. We performed the analysis. We found 42 peaks corresponding to peptide differentially expressed, and we develop and validate proteomic score. So we were using 3 different regression methods: SVM, SPLSDA, and LASSO. And you can see from this figure that the 3 different regression methods allow to obtain a proteomic score with high specificity and sensitivity. And when we look for the value of this proteomic score for the prediction of cardiovascular wealth, we show a significant improvement in the discrimination of heart failure patients, meaning that the proteomic analysis of plasma protein may help to improve risk prediction in heart failure patients. So for mass spectrometry, we were using the same patient, just the first part of the patient. So we have decided to perform a apolipoprotein profiling because from the first study, we observed that we have identified apolipoprotein which have been differentially expressed between the patient with disease who were dead after 3 years of prognostic evaluation. And so we have decided to use mass spectrometry to measure 15 apolipoprotein. So this summarizes the statistical analysis. By univariate analysis, we have selected 5 APO, and by multivariate analysis, 3 APO were still significant in this population. And from this data, we were performing IPA analysis in order to analyze and to find other protein. So I'll just show you the example. So we were measuring 15 apolipoprotein. Only 12 apolipoprotein were consistently quantified. So we were not using the data from the 3 others because ApoC3, C4, and F have inconsistent measurements. And we found that plasma level of 5 APO were significantly modulated between the case and control. Control is the alive patient. So you can see that we have by multivariate analysis, 3 of these 5 APO remain significantly, even after bone ferroni correction, associated with the occurrence of cardiovascular death in multivariated analysis. And then we analyze the regulator network of analysis of apolipoprotein. The last part is the somatic scan analysis. So as I explained to you that we were using SOMAmer. So the SOMAmer can capture protein. Then we will biotinylate the protein, and then with the photocleavable linker, we will separate the complex protein SOMAmer from the beads, and we will use a new bead that we will recognize the protein, and then we will release the SOMAmer that can be quantified. So this is interesting because we can measure simultaneously, you can see a high range of protein. The requested sample volume is low, 65 microliter, but it is very important, specifically for plasma measurement. You will have a broad dynamic range of more than 8 log. And the company can measure, you can see 100 of samples per day, and you will have the quantification for each protein. From this study, we verified that we didn't have no obvious kidney effect between the group. And interestingly, you can see on the top, it is the quantification of cystatin by SOMAmer technology, and below, the creatine measure at the hospital. And you can see that we didn't have any difference between the two groups. And in between the case and control patient, we didn't have any change in the eGFR that can be a bias for the analysis. We were also quite confident because we have a completely correlation between the BNP quantified by SOMAmer and the BNP measure at the hospital. And so we were using this approach also for better stratification of heart failure patients. And we need to use, as we have a lot of data, more than 1,000 protein for each patient. We were using a Wilcoxon test to reduce the number of modulated protein to 203. And then we were using penalized regression analysis for selection of candidate protein. So we were doing also system biology analysis, but I will not enter into detail because we didn't have so much time. And so this is the map of the selected protein by the penalized lasso. So we have 6 proteins which allow to stratify the patient between dead and alive after 3 years of follow-up. And this is just to compare the SomaScan assay with conventional assays such as ELISA. Actually, we could perform only for the 4 protein among the 6 because we didn't have any assay for the 2 other. We have validated exactly the same profile except for cathepsin S. And we have speculated it was probably because we could not have information on ELISA for the antibody which has been using because there was different isoform of cathepsin S. And we know that with the SOMAmer, we can discriminate between the isoform. So in summary, 3 different proteomic technologies have been used in the same case control study for heart failure patients, the ANCA cohort. So with mass spectrometry, proteomic score was developed, but I think it will be difficult to use in clinical practice. We have performed targeted mass spectrometry on apolipoprotein, and we show that free APO improve the prediction of cardiovascular death for patients with heart failure. It could be difficult to use in clinical practice. And we use the SomaScan screening of more than 1,000 protein, and we have a proteomic signature with 6 proteins that can be useful in clinical practice. So just some word about the Olim technology that I told you that use 2 antibodies to recognize protein. Sample compatible with Olink is all. You need only 1 microliter for any type of biology, except that if you are using for protein extract like that, you need to have no SDS because you will modify the conformation of the protein. So as I told you, there is 14 human panels, 1 mouse exploratory panel, meaning that we can measure a lot of protein. This I have already presented, so I will not detail, but I will just end with, in 2004, which strategy to use? This is my personal choice. I will say that the sample should be processed and stored for the analysis that you have chosen. And I think it is very important to use samples for this. And the technique, I will suggest use a technique requiring a low volume, but I will say samples are very important, and a technique that quantify directly with the name of the protein. Thank you.
Thank you so much for this very thorough, I would say, guideline how to go through proteomics and also how to deal with the strategies to choose what in which solutions are the best depending on the questions and so forth. It was really insightful and quite, I would say, comprehensive overview of all these approaches. I was wondering if you can give us a little bit more information about the prices per sample when you use SomaScan and Olink and stuff like that.
Okay.
You also outsource SomaScan, right? Like with Olink, you don't.
Yeah. I have done a lot of SomaScan, and actually I didn't pay.
Mm-hmm. Good.
I can explain, it's because as we have dedicated our specifically REF2 study, dedicated for proteomic analysis. So when they came to see me in the lab, I explained the way we have done the protocol to process the samples. And so for them, it was very important to have the availability of these samples because they would like to make a big study on cardiac disease. And they know that the sample I have recuperated were good quality because they were dedicated for this. So they proposed to me to not pay if I send the samples.
Okay, that's always the best way.
Yeah, so I use this technology for VANCA, but also for REF2. And actually, we have not finished to analyze the data. We made the first paper. I didn't present this. It was with the SomaScan 2, 5,014, and we are still analyzing the data. Even for this, I was working with people in Lille who were at INRIA specialists of statistical analysis. But now I work also with people in Netherlands because they have used the same technology. I met them because the main problem, I will say, I have too much information.
Yeah.
For the O-Link, I will say actually I have bought the small equipment. I'm not here to make ads about the different providers. The first study we have done with a mouse, we subcontracted to the company in Sweden. So it costs money, but you have all the information, you know, with a limited quantity of samples. But I know now there are so many requests that they have developed what they call the O-Link signature, which is an equipment but you can measure, you know, for the 96 panel, the 48 panel, and also you can make your own homemade panel, you know, using their antibody. If at the end you would like to measure only 20 protein, you can use it. And I will say, okay, I bought this equipment 2 years ago. It cost the equipment 80,000 euros. And after for the panel, actually I was an administrative technician helped me to discuss the price. And I think I have very low price. You know, I will say you will measure 88 samples. The measurement of 92 protein in 88 samples cost for me 4,000 euros.
Okay.
But I think it's a little bit more now. So meaning by pound, I have never calculated by pound. I will say maybe it will be 200, 300 euro per samples. But you will have a lot of information and you will work, I will say, a lot of time with this.
Mm-hmm. And comparing to, I had some discussions with O-Link people, and I don't know if it's SomaScan is the same in terms of how you report your data. Is it an absolute quantification, relative quantification? What types of data you get?
It's a relative quantification for SomaScan and for O-Link, except with the cytokine, absolute quantification.
Okay. So they are comparable.
Yeah.
In that regard.
I will say specifically if you are doing a clinical study, that will be important to think we can use what we name bridging. Bridging meaning that, for example, now in our study, we will add 8 samples from the Stanislas cohort, which was set up in Nancy. Because it was patient, we were follow up for, it was family, we were follow up for, I will say 40 years. So we have samples. So we put in each case for the bridging, meaning that the data that we will obtain for any our study can be used by other people if they want to use for other things. And I think now we should think in this time that all the data that we will obtain, as we know that we need to have open source, can be used. And for this, we need to perform bridging.
Mm-hmm. Mm-hmm. Yeah. We have a question from Ivan. He asks if you would have to choose one or a subset of targets, which one would you push forward clinical application for heart failure patients, probably in regard to the things that you presented?
I think I will use SomaScan or O-Link. But I will say with O-Link, I have too much data. Even with 5,000 protein, so you will have, if you didn't have, I will say 3,000 patients at least in each group, that you will, the first information you will obtain by statistical analysis will be only difference because we are all different. And so we are obliged to make a first screen, and it's this is very difficult. You know, we spend a lot of time to know how to do with this. Specifically, if you would like that if you need to obtain a prediction score that you would like other people use, that can be validated in other study, this will be. So I will say no. I prefer to use only the free panels. No, for me, the free panels of Olink, CV2, CV3, and inflammation will cover the protein that I would like to analyze. But we were performing Olink analysis for people who are working, you know, in inflammation. They just want cytokine, and they were so happy with the data, so they prefer just to pay to be. They say that we have now the experience to do this in two days, and they have a lot of information, and they work with limited amount of samples.
And when it comes to let me just read another question and then I will get back to mine. So Fabio Tindade has said a great talk. Florence, I would like to hear more about the strategy for 2024 currently with the availability of SomaScan and omics solutions. Do you think there is still place to invest on extensive protein depletion strategies such as Mars?
I don't know. I know that in Italy they have a SomaScan platform, because they contact me to help to give the protocol to process the samples, because I will say the main thing, I think the more important thing, it's really to know how the samples are processed. For me, it's because I saw so many people come to my lab just to say, I want to do proteomics, and they don't know the samples. And also I know that friends have performed analysis, and they have a change of internal people who recuperate the samples, and the data become completely different. So it's really depends on what you would like to do. If you would like to find a biomarker, and for which purpose, diagnostic, or the main problem is because it's not like with RNA. For transcriptomic analysis, if you analyze your RNA and you didn't have, you have a very low ratio, you say, okay, I didn't have, my samples are not good. In proteomic analysis, in proteomic sample, we don't have a marker of quality. This is the main problem. We have just the hemolysis. But if the sample is frozen for 10 times and then frozen, if you don't know.
Okay, yeah, makes sense. Yeah, it is really important to keep track of the integrity of the samples and the whole procedure before you enter the.
Exactly, I will say it's the more important. It's really to think what you would, you know, specifically when we start. So that's the reason I start from the biobank, because when we did this with the REF2 study, we didn't have any trouble. And we have used for microRNA, we have used for non-coding RNA, for everything. And it was working. We didn't have any problem with the data.
Yeah. I mean, it's sometimes in clinical samples, it's really hard because this is something that, I mean, we discussed this earlier during the meetings in Valencia and also in Bucharest. But the problem is, this is something that is out of control for the people who are not working in the hospital lab. So for me, for example, working in the lab that we have at the university, this part is done, you know, how they draw blood at what time points and how the blood is centrifuged, and do they really put it in the refrigerator, or it just hangs out somewhere near the, I don't know, whatever, you know, radiator or heating system or whatever. And sometimes you really don't know this, and this can dramatically influence the final outcome of the measurements. So
and you know, for REF2 study, it was a multi-center study, but I went to each lab core to explain, and I say, if the patient arrive in the night, we will not choose, because I can understand that you cannot process the samples during the night.
yeah. Fabio from Portugal, he's following up of the previous question. He says, if the samples are in a perfect condition, do depletion strategies guarantee the reproducibility that Olink and SomaScan offer?
The depletion, I didn't catch.
Yeah. Fabio, if you want, I can turn you on, and then you can ask question and explain your question. I sent you the request to unmute you, so you can be now. If you accept, you will be in the program, as they say. Okay. We cannot hear you, but the mic is unmuted.
Okay.
Now we can hear you.
Okay, so maybe some problem with the microphone. Hi, Florence and Mira and Paul. Nice talk here. I was just like wondering, let's imagine that we have our samples in perfect condition and we want to look at specific biomarkers for any kind of cardiovascular condition. I was just like thinking, well, when we think about discovering biomarkers, whether we can get a good reproducibility when we use like the Mars systems or those spin columns that deplete like the 10 most abundant proteins when compared to the Olink platforms, because we know that they have a good performance, but I'm unsure whether these antibody dependent depletion strategies are still good these days.
Yes, okay, I understand. Thank you. I would suggest with Olink or SomaMer technology to not deplete your samples, because I did this a long time ago with some, maybe it was not the Mars depletion, it was another thing, but actually we have done a mass spectrometry on the protein which have been depleted, and it was more than the measure protein. We have depleted other proteins too.
Okay.
So it was, if really, you know, the technology Olink and SomaScan, you don't need to deplete your samples.
Right.
With Olink, you will, the two antibody will recognize the protein, and they didn't have any antibody against albumin, so you don't care. And with SomaLogic, so that they are performing, you know, in the process, you know, they have the binding of the protein of the samples to the SomaMer, which is linked to a bead. But they were using 3 types of dilution of the samples. So meaning that at the last step, when they cut, you know, the linker between the beads and the SomaMer, the protein is dilated, so it is recognized by the other side. And you will have the protein which will be in, you know, with a different range of protein. So they are doing like this. So I think it is not necessary to deplete, because I'm not sure that this technology will be completely reproducible. And also you technique, you know, it's another step that you add. But if you you have to do this, because if not, you will have a big spot of albumin and immunoglobulin in the gel.
For sure. Yeah, thanks. I think that when we think about mass spectrometry alone, to find biomarkers, in the last years, I'm more in favor of using tissue as a source to discover the biomarkers than the plasma, because when we want to look at the deep proteome, as you mentioned in your presentation, with the techniques that we have now available, it's going to be difficult to make discoveries as good maybe as with Olink and SomaScan. Yeah.
You're right. It's the reason when I started to do 2D gel electrophoresis, I have started with heart tissue because I was thinking if I have modification of protein in the heart, we can see this release in the plasma. So we were using rat, but rat is not human, and it is difficult to do the same type of experiment in human samples because you will. We are using actually human biopsy, but just to validate some targets. So that's depending on which the tissue from which species you would like to work on.
Yeah. Yeah, thank you.
Actually, we were lucky with the troponin T, the phosphorylated troponin T, because we discover in the heart of the rat, we could detect in the plasma of the heart, in the plasma of the rat, and also we have validated in the plasma from the ref study. But
Right. Even if you do the discovery part on tissue, you can always use bioinformatic tools to check if it is secreted or not, and then try to monitor in plasma. So we have always other options to avoid doing like plasma screening with mass spec.
yeah.
Thank you.
It's good.
Thank you, Fabio. We have another question from Karine. She said, if it's a multi-center study, I think this is very important and a good question. If it's a multi-center study, what kind of benchmarking studies should be performed ahead of a proteomic study to make sure that the data obtained do not have differential batch and replicability issues?
So what I will do for a multi-standard study, I will say you have to prepare plasma EDTA samples. As I show you, we know that the stability could be nearly 24 hours. And actually with Olink technology, I did not present the data because it was just the data that we obtained 1 month ago. It was a multi-standard study, and we didn't have any bias from any center. But I didn't know. I was scared of this. And I was very surprised that when we perform principal component analysis, we didn't see any difference depending on the center. So that should be very important, is to give a strict protocol. And if it is possible to go to see and discuss with the people to see the equipment, I have done this. And specifically, I don't know, when we have started the REF2 study, we started at the hospital at this moment in France. They were using glass tube. And in the middle of the study, the hospital had decided to use plastic tubes. And we bought glass tube because we have half of the study already with a glass tube, and we bought to each center the glass tube to recuperate the blood, just to be sure that we will have the same condition, because we know that we could have a proteome different. So, but I think now everybody are using a plastic tube to recuperate blood samples, so that's not a problem. But really, as it was a study which lasts 2 years, we really pay attention of all the steps and going to see people.
I was also wondering if when these different approaches are used, like Olink or SomaScan and so on, so do you have like a certain bioinformatic tool that you go to, like for example, QIAGEN has like a EPA software that is more like very easy to use for RNAs. Is there anything on the market similar for proteomics?
So, for Olink, they have also tools, but I have a student from bioinformatics for the last 2 months, And depending if he was using the application, the tools on the website, the tools by RStudio, it could have some difference. So you have, yes, we have tools, but all the time you could have problem. But there is tool, and also with the SomaLogic, you know, if you are connected, you can have all the information, and also for SomaScan, as they have done a lot of analysis, they also provide all the data. So meaning that if you want, you can give access to other people if they want to compare.
Florence, may I ask one thing? First
Yeah.
of all, thank you so much, because this is a very illuminating webinar, because all the details that we wanted to hear and to learn.
Thank you.
First. Second, perfectly translational perspective, but we need to really go to those people who are getting the blood samples and teach them, and maybe have, if possible, placing a person from our labs there sometime when there is a session of blood sampling or so. So it's so important. The pre-analytical phase is so important, quite obvious, but still to be fixed everywhere. I have a question on the first, the case control cohort that you showed. 78 males versus 6 females. So basically no females. That means that if you take only males, these are the data. And we need to really cover the issue of the dimorphic, sexually dimorphic possibilities of that.
You're right. It was, the ANCA study has started actually in 1998 by Dr. Pascal de Groot. So each patient who came to the hospital for heart failure, he recuperated blood samples and he sent to our lab. I was not in the lab in 98. I just arrived in 2000. But that's the reason at that time, when starting in 98, and also to have a follow-up of 3 years. So we stop, we have to call all the patients. At this time, you have more men who have problem of heart failure than women. And it was all patients with heart failure with reduced ejection fraction.
Okay.
Specifically with the heart failure with preserved ejection fraction, we will have more women and we need to do all the work again. And so that's the reason I think it is very important for the bridging to be sure to recuperate all the data that we have already done for the new studies.
Yeah. The other question is the $1 million question, that is it possible to have a one sample fits all or some omics? This is the big question for everybody. Probably not, but for sure a good sample maybe can fit proteomics plus what? Transcriptomic maybe not, because this is not platelet poor, or a fraction of that can be prepared as platelet poor.
Yeah, I was really thinking at the moment to have a perfect sample that we can use as control all the time. But it was difficult. Even from patients, we recuperate and we pull and we say, okay, it will be our control group to compare. But it's only a limited amount. You never imagine for how long you will need to use it. And also the other question, and actually we have an answer, because from this retrospective study, because the patient was started to be recruited in 1998, we analyze our SomaScan data depending on the time of collecting samples, because using from 98 to until 2010. And we didn't see, because it was plasma EDTA, but because we have all the connection between the hospital and the lab, we didn't see any difference.
Great. So 12 years of storage.
Yeah. But I don't know for 20.
Yes, that's
great.
That's always a problem with retrospective studies when you learn, you have new techniques, new markers, and then you want to go back and exploit existing biobanks, but then you realize, oh wait, that can be quite challenging.
And also the cost, because I have all the freezer full of science. But it costs a lot of money, specifically now as the electricity has increased.
Right. Yeah, it's always a big problem. Yeah.
So I know, I was in European consortium homage, and so there was collected samples from different study, and actually the consortium is over for nearly I will say 5 years now, but the people who were in charge of all the samples, they say we need to throw.
Yeah.
Because you have the money from Europe for 5 years, and you didn't have any money and it costs a lot. It costs a lot. If you want to have the samples because you have a new idea, you will have to pay for this.
Yeah. Do we have any more questions for Florence and her fascinating experience? No.
Because I'm an older researcher.
No. It's just the matter. It's the matter of experience and excellence, not the age. We are not going into that direction.
This is what we need in this series of webinars, because these are true hands-on information. So this is something that is really enriching us, all of us, with all the details, all the the fine-tuning on the different aspects. So thank you so much.
Yeah, thank you.
Thank you for raising awareness about pre-analytical stuff, because I really think that's the key of integrity in the later stages. So, and also reproducibility between different groups and so on. Hopefully we will manage in next 2 years to reach to the point where people are much more aware than it is the case now.
Really, you need to spend time at the beginning, just how you will do.
Yeah. Thank you so much one more time. I thank everybody for the attention and for participating in this discussion. The webinar will be present on YouTube in maybe a couple of days. Also, have a nice summer. Enjoy as much as you can, everybody, and then see you sometime in September. We will get the information when we know, but we need to a little break. So thanks, everybody. Have a nice summer.
Thank you.
And see
Bye.
you.
Thank you. Have a nice summer. Thank you so much.
Bye-bye.